All right. So I tried to make this earlier, realized 30 minutes in that it was not recording. Yeah. All right. So we're going to restart this and do it again. And I have not lost any of my pizzazz. So here we go. This is going to be the lecture on the blood, the components of the blood, and what we get inside of the blood. So what we're talking about here are the agents that we find inside of the cardiovascular system, that being the body's transport network. Right? So the cardiovascular system is our network of vessels that we discussed in the previous lecture. We are going to be transferring around the bodily fluid of blood. Inside of the blood, we are going to have transporting agents. All right. We're going to be transporting things like nutrients, carbohydrates, amino acids, fatty acids. We're going to be carrying around waste products like carbon dioxide, lactic acid, uric acid, things of that nature. Also, chemical messengers in the case of endocrine hormones and other things of that nature, enzymes, whatnot. So we see that the cardiovascular system transports our blood. The blood is going to transport a lot of these different components that our body needs. We're going to transport dissolved gases such as oxygen and carbon dioxide, nutrients, hormones, metabolic waste. It's going to regulate our interstitial pH values. We keep our pH of the blood around 7.35 to 7.45, right? That's going to be a slightly alkaline, slightly basic constituent of blood. We're going to keep it in that range. Keeping it in that range is going to be because of ion composition, right? The concentrations of ions within our blood is highly going to dictate what the pH of the blood is. It's going to restrict our fluid losses, especially at sites of injury, by clotting the blood and cutting off blood flow to that area of open wound. It's going to defend against toxins and certain pathogens that come into the bloodstream. And finally, stabilizing body temperature by diverting blood flow either towards the center of the body if we are cold, or dilating the vessels and sending blood towards the surface of the body and the skin if we are warm, to try and dissipate some heat. The blood is categorized as a connective tissue. It is liquid connective tissue. It has two components. That is the fluid plasma and the formed elements. The cells of the formed elements are in suspension, meaning they are not dissolved, not in solution with the rest of the blood. The formed elements are going to include the red blood cells, white blood cells or leukocytes, and platelets. Blood volume is going to be dictated by body size. Generally, for males, we generally have a larger body on average, so therefore we're going to have more blood, 5 to 6 liters. For females, slightly smaller on average, so we're averaging 4 to 5 liters of blood through the entire cardiovascular system. Characteristics of the blood: we do keep a temperature that is slightly increased above body temperature. Normal body temperature is about 98.6 degrees Celsius. Normal blood temperature is about 99.2, right? Sorry, Fahrenheit. That would be 38 degrees Celsius. Blood is going to be much more viscous than water, meaning it's thicker than water. It's got all of these suspended agents and dissolved agents in solution that are going to give it a very thick consistency. So it is going to be thicker, it's going to be stickier, and it's going to give us more resistance to being pushed than water does. It's going to be more viscous because of all of these formed elements and dissolved things in the blood. As I stated before, we keep that pH around 7.35 to 7.45 on average. This is going to be an alkaline or basic pH. We keep that slightly above neutral, which is 7. To collect blood and to analyze blood, we are going to get blood from veins. During venipuncture, we typically use a vein that is going to be very superficial and easy to access. A common site is going to be the median cubital vein in the fossa of the elbow, or the divot of the elbow. We're going to do this for large blood draws. We use veins because they are easier to deal with. They are more superficial, they have thinner vessel walls, and they have a far lower blood pressure, so not nearly as much change in the pressure that is exerted in these vessels. If we need a small amount of blood for something like an insulin stick or getting blood glucose values, we typically can collect from smaller peripheral capillaries, right? We can do this with fingertip pricks. We see that with usage of blood glucose monitors. Also, if we need to do a tag on the earlobe, we can do that as well to get a small portion of blood. Occasionally, if we need to do something like analyze the gas efficiency inside of the blood. We need to reach the arteries. By the time the blood has reached the veins, it has been deoxygenated, and that doesn't give us an indication of how much oxygen was there before the tissues extracted it from the blood. So we need to get arterial blood in order to see the efficiency of gas exchange at the lungs before it reaches the tissues and before that oxygen has been taken out of the blood and utilized. So our checkpoint here, the 5 functions of the blood. All right, 5 functions of the blood. Transporting, all right? Transporting nutrients, transporting chemicals, transporting waste. pH, keeping things in a neutral pH value, right, around 7.4. Temperature, we're going to dictate changes in temperature, sending blood to the periphery of the body if we're warm, moving it back towards the center of the body if we're cold, right? And we are going to transport everything we need through the blood. The 2 components that make up the whole blood are going to be the plasma and the formed elements. Venipuncture is a common technique because it is simple, right? It's easy to find a vein. It's easier to puncture a vein. It's easier to stay in a vein, all right? Less hassle. And we can get a large sample of blood from a venous structure. The blood plasma, all right? The blood plasma is going to account for most of the fluid volume of whole blood. It's going to account for 55% of that volume, okay? It also accounts for most of the extracellular volume that we have in the body. Plasma is mostly going to be water. So it's going to contain about 90% water. About 7% of it is going to be plasma proteins, large plasma proteins. And then 1% is going to be their other solutes, such as our dissolved gases, dissolved nutrients, and hormones. The types of plasma proteins that we find. Number 1, albumin. This is going to be the most abundant and largest. About 60% of our plasma proteins are going to be albumin. These are big for maintaining osmotic pressure. They're relatively large, so they do not diffuse across permeable membranes very easily, so they're going to exert pressure on water, drawing water across the membrane. So they're going to maintain our osmotic pressure gradient against water. Our second is going to be globulins. These are going to make up about 35% of our plasma proteins. They're going to act as either transporters or they're going to act in immune functionality, whether that be as part of the antibody or in the immunoglobulin family. Third is fibrinogen. These are mainly clotting factors. All right? Fibrinogen is going to make up about 4% of our plasma proteins. It's going to function in blood clotting, and its dissolved form or its converted form is known as fibrin, which is insoluble strands that are going to form clots. Plasma proteins, right? The plasma proteins are going to be what is making up the serum. The plasma, if we take away the clotting proteins, the fibrinogen, is called serum. So without the ability to clot, the plasma of the blood is just known as the serum of the blood. Most of our plasma proteins, most of them are going to be synthesized in the liver. We get about 90% of those synthesized in the liver. When we find disorders of the liver, we find our plasma proteins are going to be impacted pretty much right away. So things like albumin and globulin formation are going to be poorly administered, inadequate, and so therefore we have poor transport of substance through the blood, and we have a lot of metabolic breakdown products that are not supposed to be there if we have liver dysfunction. Other solutes in the plasma besides plasma proteins, we have organic nutrients. These are going to be the nutrients taken up by the intestines, such as carbohydrates, lipids, amino acids, and vitamins and minerals. We have electrolytes in the form of ions. These are going to be in no particular order: sodium, potassium, calcium, magnesium, chloride, hydrogen, and then buffers like phosphate, bicarbonate, and sulfate. We have the organic wastes, which are made by metabolism, right, such as uric acid, ammonium, bilirubin, urea, things of that nature. So our checkpoint, 3 types of plasma proteins. Remember, we have globulins, we have albumin, and we have fibrinogen. If we were to decrease the effect, right, if we were to decrease the amount of plasma proteins, what would the effect be? The effect of decreasing plasma proteins: 1, you would have less transporters in the blood. 2, we would have less globulins to make immune cells or antibodies. 3, we would have less transporting proteins, so we wouldn't be able to more efficiently transport substances through the blood. There would be a lot of different things that go wrong. So our first formed element of the blood is going to be the erythrocyte or the red blood cell. Red blood cells are going to account for 99% of the formed elements in the blood. We have a massive volume of red blood cells compared to any other cell type. So it's going to contain a red pigment that we know of as hemoglobin. Inside hemoglobin is the heme group containing a centralized iron molecule. This is going to be able to transport oxygen and carbon dioxide. The oxygen bound to the heme, the carbon dioxide bound to the globulin unit. Red blood cells are going to be measured in number per microliter. So the red blood cell count is going to be per microliter. Usually in men, larger amount of blood volume, usually have about 5.4 million red blood cells per microliter. In women, we have a lesser value, about 4.8 million per microliter. The percentage of whole blood that is red blood cells is measured as the term hematocrit. Right? So your hematocrit is the percentage of red blood cells that makes up your whole blood. Sometimes you'll also see it reported as packed cell volume. So if you see PCV or VPRC, that's going to mean the same thing as hematocrit. In men, usually the hematocrit is around 45% to 46%. Hematocrit in women is usually a little bit lower, around 40 to 42%. The structure of the red blood cell is specialized. It's going to be specialized to maximize surface area for minimized volume. It's going to be able to transport oxygen and carbon dioxide. That maximized surface is going to come because we have a biconcave disc. So we have a very flat disc shape with a biconcave surface, giving it much more surface area. It increases the rate of diffusion between the cytoplasm and the plasma because of this large surface area to volume ratio. It is also able to wiggle and squeeze through narrow capillaries because of its thin disc shape. During red blood cell formation, all of the organelles are going to be lost. So it does not have any organelles inside, okay? It can't go through any cell division since it doesn't have a nucleus. So red blood cells circulate until their time of death. They do not repurpose, they do not replicate. For energy, they are solely relying on anaerobic metabolism of glucose. The hemoglobin structure, our main functional unit is hemoglobin, right? And inside of the hemoglobin, we have a subunit that is going to be a heme unit, right? Hemoglobin is going to account for 95% of all of the protein content of the red blood cell. So each hemoglobin unit is going to contain 2 pairs of globulin proteins, and each one of these is going to be able to bind to an oxygen, right? So we have 2 pairs, meaning 4 globular proteins, and each subunit, each of the 4, can bind to an oxygen atom. We bind oxygen via the heme groups. We bind carbon dioxide via the globulin units. The oxygen-heme bond is going to be fairly weak, so it easily diffuses off. In the case of high plasma oxygen, this is going to cause hemoglobin to retain oxygen. Right? So if we have high amount of plasma oxygen taken in, then the hemoglobin is going to want to bind to oxygen and hold it. This is going to create a saturated heme molecule. This is going to occur when blood circulates through the lung capillaries where there is a high concentration of oxygen and a low concentration of carbon dioxide. The opposite mechanism occurs at the tissue level when we have blood circulating through the systemic capillaries, giving off oxygen. There's a low amount of plasma oxygen at that level and high carbon dioxide. This is going to cause the hemoglobin to want to release its oxygen so it can go to the tissues and bind to the carbon dioxide to transport it back within the venous blood. Any sort of anemia is going to be the body's reduction in oxygen carrying capacity. So this is going to be caused by one of 2 things. A lack of red blood cells, so low red blood cell count, which is low hematocrit, or a reduction in the hemoglobin units. So the hemoglobin units inside of red blood cells can occur, and this is going to occur because of iron deficiency. So if there's iron deficiency, then we're going to have a deficiency in heme unit. And if we have a deficiency in heme unit, then we're not able to bind oxygen even though we have the red blood cells there. They just don't have that centralized heme to bind. Symptoms of anemia are going to be pretty generalized. They're going to be vague muscle fatigue and weakness, a generalized malaise, lack of energy, lethargy, things of that nature. Red blood cells have a relatively short lifespan, about 120 days. They undergo a lot of wear and tear and friction because of their squeezing through the small capillaries and bouncing against the vessel walls that they come across. So they do undergo a lot of mechanical torsion as they move through the vascular system. So the lifespan is about 4 months or so, about 120 days. About 1% of all of our red blood cells are replaced every day, which means that 3 million new red blood cells enter our circulation every second, which is a lot. So we have a high turnover there. So it means every 120 days, your entire red blood cell population is recycled. During that breakdown at the end, when we get to that 120-day mark, the red blood cells are broken down, and most of the components that we find in the red blood cell are able to be used again. So our resident immune cells of the macrophages that are located in the liver, in the spleen, and the red bone marrow all engulf our red blood cells and are able to remove the hemoglobin units from them. Only a small percentage, about 10% or so of our red blood cells that are going to die do so in the bloodstream. Most of them are taken to the liver or the spleen to be degraded. If they do die in the bloodstream and are not able to make it, then this is called hemolysis, right? So they hemolyze inside of the bloodstream. Hemoglobin breaks down into blood, and the hemoglobin units that break down in the blood are going to form what we call hemoglobinuria. Okay, so hemoglobinuria is going to be a red or brown coloration in the urine, and you will see this if you have an unusually excessive amount of red blood cells that are being destroyed and broken down in the bloodstream. All right, so we have 3 steps in hemoglobin recycling. Number 1, our globular proteins are broken down into amino acids. The iron that is within the hemoglobin unit is extracted and stored inside of the macrophages or released in the blood to be bound to a protein known as transferrin. What's left over of the heme group is going to be converted to a protein that is known as biliverdin. Biliverdin is then sent to the liver. It's converted to orange-yellow bilirubin in the liver. The liver is then going to absorb that and put it into the bile. Okay, so you lose pretty much all of that bilirubin content via excretion in the feces when you lose it with the bile. And in the large intestine, it is converted to what we call urobilins and stercobilins. And these are going to give the feces their brown color. When we get dysfunction of red blood cells, the liver, degradation, even the gallbladder, we see things like jaundice. Okay, so jaundice is because of that bilirubin buildup. Jaundice is a condition that is yellowish coloration, whether that be of the eyes, the nails, and the skin. This is going to be a sign of excessive levels of bilirubin in the blood, which of course is going to give us this yellowish pigment. If we have excessive bilirubin in the blood, this can indicate excessive red blood cell breakdown, excessive hemolysis. This can also show for excessive liver dysfunction or gallbladder dysfunction. If we have gallstones, this can block our bile ducts and cause failure of bilirubin to be excreted in the feces, which means that it's going to filter back into the bloodstream. Or we could have the failure of liver to absorb and excrete bilirubin. That can mean that liver dysfunction is pretty rampant there. Iron reserves are going to be present in males to a higher degree than females. Generally, men have about 3.5 grams of iron or so in the body. 2.5 of that is going to be bound in hemoglobin, and we typically reserve about 1 gram or so stored inside of the liver and the bone marrow. Women have a little bit less, about 2.4 grams. 1.9 of that is stored in hemoglobin, and about half a gram is in reserve in the liver and the bone marrow. If we have inadequate iron intake, then iron deficiency anemia may occur. Again, this is where we have a deficiency of hemoglobin units, so not necessarily a deficiency of red blood cells. We might have adequate red blood cell concentrations. We just have a deficiency in the ability to make hemoglobin with active heme units. So this is going to be iron deficiency anemia. Red blood cell formation is known as erythropoiesis. Erythropoiesis is going to happen within the red bone marrow. In the developing fetus, it happens in the yolk sac for the first 8 weeks of development. In the adult, of course, we get it in the red bone marrow. The red bone marrow that secretes red blood cells or makes them is known as myeloid tissue. We need cofactors for this, right? And in order to do this, we need vitamin B12. Vitamin B12 absorption requires intrinsic factor. If we have a vitamin B12 deficiency, this leads to what we know as pernicious anemia. All right, so some key stages in red blood cell maturation. There are embryonic stem cells that are going to differentiate into different types of cells that are going to lead to the formed elements. One of those is going to be a multipotent stem cell called a hemocytoblast. A hemocytoblast is able to make myeloid stem cells, okay? Those hemocytoblasts are going to make hematopoietic stem cells, and they're going to produce myeloid stem cells. The myeloid stem cells are going to differentiate into erythroblasts. Erythroblasts are immature red blood cells that are stuck in the bone marrow and are synthesizing hemoglobin units. Once we leave the red bone marrow, the nucleus is shed, and this is known as what we call a reticulocyte. When we regulate erythropoiesis, which is the formation, of course, of red blood cells, this is going to be regulated by oxygen concentrations. So it is going to be stimulated by low tissue oxygen, which is known as hypoxia. If low oxygen concentrations are registered by the kidney, this will trigger the release of a hormone known as erythropoietin, or EPO. EPO is going to be released in several different conditions. One would be if we have anemia. 2 is if we have blood flow to the kidney being decreased. 3, if we have oxygen content of the air in the lungs going down. And 4, if we have damage to the respiratory system or the respiratory surfaces. Erythropoietin is our hormone that is going to target the myeloid stem cells. It's going to speed up the rate of maturation of red blood cells and stimulate more production. It is also essential in medical clinical care, especially for those who have had a large degree of blood loss. If we have a large degree of blood loss, that means that we have a large degree of red blood cell loss. So we have to supplement that and get it back up and working so we can give infusions of EPO to help patients who have had a large amount of red blood cell loss due to things like trauma, severe injury, infection, or cancer. In a normal person, EPO, if given to too high a degree, can make the hematocrit too high. So if we push our hematocrit too high, the red blood cell concentration could cause the blood to become very viscous. If that's the case, then we can cause blockage of vessels, and it can lead to a lot of different problems like stroke, heart attack, deep vein thrombosis, a bunch of different things. All right, next we are going to have blood types. We have three different blood types that are going to be traditional that we think of, A, B, and O. We have a fourth that we come in with known as the rhesus factor, and this is going to be whether we get the positive or negative delineation on that blood. Blood typing is based on antigen-antibody responses. The antigens are on the surface of cells, and they are going to be what the antibodies are going to target in order to trigger an immune response. The surface antigens on your own red blood cells are considered self or considered normal. So the antibodies circulating around for the opposite antigen don't mess with your red blood cells. The presence or the absence of an antigen on the red blood cell is going to determine the blood type. We have 3 blood types that are generally associated. We have A, B, and O. Then we have the rhesus factor, which is also known as antigen D. Type A blood is going to have only the type A antigen. Type B blood has the only type B antigen. AB has both of those antigens, and type O blood has neither type A or B antigen. Then we see the rhesus factor, the rhesus antigen. This is going to be indicated by a positive or negative delineation. So our full blood type is going to be whether we have A or B, we don't have A or B, and if we have rhesus factor or not. So our antibodies, these are also known as agglutinins. right? These are going to attack the surface antigens on red blood cells that are not your own. So they attack the foreign antigens on the red blood cells that we would find if we gave transfusion of the blood and it was the wrong antigen type. So for instance, type A blood contains anti-B antibodies, type B anti-A, type AB contains neither antibody, and type O contains both antibodies. So we have to make sure that we are aware of this during transfusions. If we give patients a blood type that has the opposite antigen of what they have, and they contain antibodies for it, then we immediately could see those antibodies attack and destroy the red blood cells that have been transfused into them, right? This can cause agglutination, clumping up of the red blood cells in the bloodstream, and this can cause hemolysis to a large degree. These are referred to as cross reactions. So the difference between our ABO and rhesus factor blood types, the anti-A and anti-B antibodies are spontaneous. They're going to develop right away. We don't need any sort of exposure to a foreign antigen. They just grow. If we have type A blood, then the anti-B antibodies will develop very quickly within the first month, 6 months of life. The rhesus factor antibodies, however, are not automatically growing. So the anti-rhesus factor antibodies, or inside of the rhesus negative person, they do not develop unless we expose the person to rhesus positive blood. Exposure to rhesus positive blood can happen accidentally during transfusion or during childbirth, but if not, then we will not develop rhesus positive antibodies. Testing for blood compatibility is going to be extremely important, especially during transfusions. We have to make sure that we are transfusing blood that is going to be accepted by the patient's body. So we involve 2 steps in determining blood compatibility. We have to determine blood type, whether that be A, B, or O, rhesus positive or negative. And we have to do a cross-match test, right? This means that we're going to have to mix the blood of the patient with the blood of the donor. And once we put that together, we're going to put it with antibodies. So we put it with the anti-A, anti-B, and anti-rhesus factor antibodies. If we get a reaction, if clumping occurs, that means that the surface antigen that's there is going to be attacked within the blood. So if we have clumping with anti-A and anti-rhesus factor, that means that we indicate the blood type is going to be A positive. So checkpoint here, which blood types can be safely transfused into a person with type AB blood? Well, if we have type A and B, that means we have neither antibody for A and B. So we can transfuse type A blood, type B blood, or type AB blood, or even type O blood. Type AB blood is what we call the universal recipient. Why can't a person with type A blood safely receive blood from a person with type B? That is because the person who has type A blood is going to have an antibody against type B. So they're going to have antibodies circulating around that will target the transfused blood and agglutinate it to be destroyed. All right, after our red blood cells, we have the leukocytes, which are the white blood cells. These are the second most populous of our formed elements. Right? White blood cells are going to be considerably larger than red blood cells, but they're going to be much less in number. They're going to be for our immune response, helping to remove toxins and waste and damaged cells and debris. They do contain nucleuses and other organelles, so they are different than the red blood cell because they are able to divide and grow. They are numbering about 5 to 10,000 per microliter of blood, comparatively to the 5 million that we had for red blood cells. So we have very little concentration of white blood cells normally. There are 2 categories. We have granulocytes and agranulocytes. The granulocytes are the neutrophils, eosinophils, and basophils. Our agranulocytes are the lymphocytes and the monocytes. So the white blood cell circulation is going to be dictated by a couple of different things. They're capable of amoeboid movement. They're capable of moving on their own, able to move through different vessels and squeeze their way out into tissue that needs it. When they migrate outside of the bloodstream and they move into tissues, this is a process known as diapedesis. They are also going to follow pathogenic trademarks. So they're going to follow markers for places of injury or places of infection. And this is called positive chemotaxis. So they are attracted to specific chemical stimuli, which can guide them to areas that they are needed. Neutrophils, eosinophils, and monocytes are what are called phagocytes, which means that they are going to engulf and destroy pathogenic bacteria or pathogenic molecules by ingesting them. Part of the positive chemotaxis response is this ingestion of those materials, because the breakdown of cellular debris is able to then signal for the other white blood cells to migrate to that area. The granulocytes are going to be the neutrophils, basophils, and eosinophils, as we know. The monocytes and lymphocytes are the agranulocytes. The neutrophils, basophils, eosinophils, and monocytes are all part of the innate response. They are part of the initial innate immune response. This is non-specific. This is going to be our initial startup immune response that is going to respond to any sort of threat. Lymphocytes, T and B cells, are going to be responsible for the adaptive immune response. These are going to be more specific. Here we develop antibodies and we develop specific cellular targets that are going to be able to attack specific pathogens. So our types. Start out with the innate immune response. We see neutrophils. Neutrophils are going to constitute the most of our white blood cells. So they constitute 50 to 70% of the total circulating white blood cells that we have. They usually have a multilobular nucleus, which means 2 or more lobes. They're usually the first white blood cell on the site, so they're the initial responder or the first responder of the white blood cells. They're phagocytic, as we mentioned previously, so they are able to engulf and digest bacteria. And during this engulfing and ingesting the cellular debris from that bacteria is then going to be a positive chemotactic response for the other white blood cells. They have a short lifespan, generally around 10 hours or so. That can be greatly decreased, however, if they're actively ingesting and engulfing pathogens and debris, sometimes as low as 30 minutes. Eosinophils are going to make up a smaller portion of the white blood cells, generally about 2 to 4%. They're similar to neutrophils in size. They have stained granules upon imaging that are going to stain deep red, and they're going to have a bilobe nucleus, or 2 lobes to the nucleus. They are still going to do phagocytosis, just like the neutrophil does, but in addition, they are also able to attack through exocytosis of cytotoxic compounds. They're going to be mainly active during parasitic infection and also partially during allergic reactions. So if we have an allergic reaction, or we have something like a ringworm, hookworm that's become infested in our body, then we do have increasing numbers of eosinophils during that particular time. Basophils, so the next one. Basophils are going to be the least in number of the white blood cells, going to be less than 1% of the total number of circulating white blood cells that we have. Their granules are going to stain a very deep purple. Okay, so they're going to be a very deep purple stain. They are also going to be prevalent in allergic reactions. They are going to secrete a large amount of heparin and histamine. Heparin is going to prevent blood clotting. Histamine is going to dilate blood vessels and promote inflammation. Next, we have monocytes. These are the largest white blood cells. They are variable in population from about 2 to 8%, and this is highly dependent on how many of them are actively converting into macrophages at any one time. They are very large, about twice the size of the neutrophil. They have a very large kidney bean-shaped nucleus as well. They're going to be able to migrate into tissues, and when they do migrate into tissues, they're going to be converted to macrophages, and they become the tissue-resident macrophages that we find in various selections. They are very aggressive in their phagocytosis, whether they be monocytes or macrophages. They will go ahead and ingest any sort of foreign substance that they come across. Our last category is the lymphocyte. We have the T and B lymphocyte. These are both the adaptive immune response cells. These are our second most populous immune cell overall, constituting about 20 to 40% of all circulating white blood cells. They're going to be the closest to a red blood cell in size. So they're pretty close to a red blood cell as far as their actual size is concerned. And the nucleus is going to take up pretty much all of the cell. They're going to be able to attack foreign cells in the terms of the T cells, and they're able to target foreign cells with antibodies in the case of B cells. How we count for white blood cells is going to be with a differential white blood cell count. We are going to look at this in terms of number per microliter once again. Differential white blood cell count is going to look at how many white blood cells we're going to find of different types per a sample of 100 white blood cells, right? So typically for that sample of 100 white blood cells, you would want to have about 50 B neutrophils, right? You want about 2 to 4 to be eosinophils, maybe 1 basophil, and maybe 8 or so monocytes in that. A reduced number of white blood cells is called leukopenia. An excessive number of white blood cells is called leukocytosis. Leukemia is cancer of the blood-forming tissue. So for leukemia, this is going to be indicated by either leukocytosis or by abnormal and immature white blood cells and immune cells circulating in the bloodstream. White blood cell formation is going to happen in the red bone marrow, just like we had for the erythrocytes. Inside of the red bone marrow, we have cells known as hemocytoblasts. The hemocytoblasts are going to produce lymphoid stem cells. Okay, so the hemocytoblasts are differentiating into either myeloid stem cells or lymphoid stem cells. The lymphoid stem cells are going to create our lymphocytes. All right, and this is by lymphopoiesis. The lymphocytes are then going to migrate from the bone marrow into lymphatic tissues, whether that be the thymus for T cells or the spleen, or staying in the bone marrow for B cells. This process is regulated by thymosins, which is the hormone secreted by the thymus, and also our antibody exposure to antigens. The myeloid stem cells are going to differentiate into all of the other formed elements. So our platelets and red blood cells are going to be differentiated into, because of the myeloid stem cells, our lymphocytes are going to come from lymphoid stem cells. So we identify the types of white blood cells. We had neutrophil, basophil, eosinophil, monocyte, and lymphocyte. What type of white blood cell would you find the greatest numbers in an infected cut? An infected cut, you would find neutrophils to be at the greatest number. They are the most abundant white blood cell and also the first responder. What type of cell would you find elevated numbers in a person with a large amount of circulating antibodies to combat a virus? Here you would have a large amount of B lymphocytes carrying around the antibodies for the antigen on the virus surface. And basophils respond to an injury by secreting heparin and histamine. All right. So remember, our basophils are going to secrete heparin to stop blood clotting, and also to histamine to promote blood vessel dilation and inflammation. Our last element is the platelet. Right? The platelet is going to be specific to mammals. In non-mammals, we have what are called thrombocytes, and they still retain a nucleus. In humans and other mammals, platelets are going to be fragments of cells. They don't actually have a nucleus themselves. So platelets exist as cell fragments that are going to have large cells known that are coming from large cells known as megakaryocytes. The platelet role is to initiate the clotting process. They're going to circulate for about 9 to 12 days of a lifespan. The normal count is anywhere between 150 to 500,000 per microliter of blood. If we have a low count of platelet, it's going to be thrombocytopenia. If we have a high count of platelet, it is thrombocytosis, right? So the difference between platelets and thrombocytes, platelets are going to be cell fragments of megakaryocytes. Thrombocytes are platelet cells that still have a nucleus. Primary functions of a platelet, again, initiate the clotting process and help to close off injured blood vessels. Hemostasis is the process of stopping bleeding. So there are 3 phases to hemostasis. First is the vascular phase. All right. The vascular phase is going to happen right away, as soon as injury occurs. Blood vessels are going to contain smooth muscle, we know this, in the endothelial lining. As soon as we have damage to a blood vessel, that will immediately trigger contraction of the smooth blood vessels, smooth muscle fibers around that vascular area. This is going to immediately constrict the vessel, decrease the vessel diameter, slowing down and stopping blood flow to that particular vessel. This is going to last for about 30 minutes after injury. Secondly, we have the platelet phase. This is going to start about 15 seconds after injury or so. The platelets are going to attach to that endothelium that's been damaged and also to the collagen of the exposed connective tissue around in the tissue site of damage. As soon as platelets start to stick, they aggregate more and more platelets as they arrive to that site, and they stick to each other, forming a platelet plug. The coagulation phase is going to be the actual clotting. So the coagulation is going to start about 30 seconds or so after injury. This is where we have the actual clot form. This is going to be a pretty complex process. So we have a signal cascade or a clotting cascade that's going to occur during this time. The end result of this cascade is always the same. It's fibrinogen conversion into the insoluble fibrin strands, which are going to form a mesh. The fibrin mesh is going to trap different cells and the more platelets that come, and that's going to form the actual clot itself. The clotting process is going to require a lot of different mechanisms and a lot of different nutrients. Clotting process is going to require several different factors. We need things like calcium ions, we need vitamin K, and we also need 11 different plasma proteins. All of these proteins are going to be converted from inactive forms known as proenzymes into active enzymes during the reaction. The liver is going to synthesize most of these clotting proteins, right? The clotting proteins and the clotting factors are going to interact in a signal cascade that is going to lead to one reaction after another. There are two pathways of blood clotting. There is the extrinsic pathway and the intrinsic pathway. The extrinsic pathway is going to begin outside of the bloodstream. So this occurs when we have a breakage of a blood vessel or injury exposing it to the external environment. The damaged tissue is going to release what we call tissue factor. And at that point, tissue factor is going to start forming a clot. The greater amount of damage, the more tissue factor is going to be released, the faster the clotting is going to occur. Tissue factor is going to bind with calcium around the area and factor 7. All right. That combination of calcium, factor 7, and tissue factor is going to form an enzyme that is able to activate what is known as factor 10. And factor 10 is what goes into the common pathway of clotting. The intrinsic pathway is going to be slightly different. This is going to begin inside of the bloodstream. So this can begin outside of injury or any sort of damage to a blood vessel. It can particularly happen if we have breakage of a blood vessel due to aneurysm, or if we have plaque buildup from arteriosclerosis, cholesterol buildup on the walls of the arteries and veins. It's going to begin in the bloodstream. It starts with the activation of a proenzyme that's going to be exposed to collagen fibers. It's going to proceed to help form what we call platelet factor. And that is going to continue to be secreted from platelets and continue to aggregate more platelets as they come around the site. Several reactions occur past then, and then we get to the activation of factor 10, which again is going to go into the common pathway. So our extrinsic pathway is going to eventually lead to factor 10. The intrinsic pathway, again, is going to lead to factor 10. And after that, both of them are the same. So when we get to factor 10 activation, we lead into the common pathway of blood clotting. Factor 10 is going to activate several different factors here. We have prothrombin activator. Prothrombin activator is an enzyme that's going to convert prothrombin into thrombin. Thrombin is then going to work on fibrinogen to convert fibrinogen into fibrin. And we also have stimulation of tissue factors and platelet factors. This is going to be a positive feedback loop, and it's going to keep feeding back on itself until we get clot formation that's closing the entirety of the wound area. All right, after we have clot formation and tissue healing, we need clot retraction and removal. So the fibrin network is going to be able to trap the red blood cells and platelets, which form the clot. The platelets are going to contract. At platelet contraction, this is going to pull the torn edges of the vessel closer together, and this is called clot retraction. After the tissue repair has almost finished, we have to dissolve the clot. And the clot dissolves through a process known as fibrinolysis, the breakdown of those fibrin strands. We have a protein known as plasminogen. Plasminogen is going to be activated by thrombin that's present in the bloodstream and tissue plasminogen activator, or TPA. Plasminogen is going to produce a protein known as plasmin. The plasmin is what goes in and actually physically digests the fibrin strands. And once we break down those fibrin strands enough, the clot will begin to dissolve and break away. So our last checkpoint questions: if a sample of red bone marrow has fewer than normal megakaryocytes, what body process would you expect to be impaired? Megakaryocyte deficiency would impair platelet formation, which would impair the clotting process. So if we have too few megakaryocytes, then we will end up having very little platelet formation, and then we will end up impairing the clotting process. Two alternate pathways of interacting clotting proteins lead to coagulation or blood clotting. How is each pathway initiated? All right, again, we had the extrinsic pathway. This is going to be beginning outside of the bloodstream. All right, this is going to start when we have damaged tissues, and this is going to be the release of tissue factor. So tissue factor is going to combine with calcium and factor 7, which initially starts the factor 10 activation. Intrinsic pathway is going to be inside the bloodstream. Here we have proenzymes exposed to collagen. This proceeds from platelet factor released from aggregating platelets, and it's going to lead to factor 10 activation. Finally, what are the effects of vitamin K deficiency on blood clotting? Vitamin K deficiency is going to lead to that activation of fibrinogen into fibrin. Fibrinogen into fibrin process is going to be diminished greatly if we don't have vitamin K. And if we aren't able to create fibrin, then we are not going to be able to create an actual clot. So we're not going to be able to create a mesh or a clot if we do have that. So vitamin K deficiency is going to lead to a deficiency in the ability to actually create that fibrin mesh and create the clot itself. All right, so those were the components of the blood, what they are, what they do, where they are, and where they go. Hopefully it recorded this time. I know it did. So if you like the channel, please like and subscribe to it. If you want more content, go to the Patreon, patreon.com/twistedscience. Thank you all for listening to our lecture on the blood. I'll see you next time.